Welcome to the August Baltimore CCT Collaborative. This quarter's cases and stuff were brought to us by the folks from MEC. So they put together 2 cases for us. I think this is going to be a really good one. There's a real unique case. It's our second one. Actually, both of them are pretty unique cases. I know that Dr. Lawner is going to be a little bit delayed. So hopefully he can jump on and add some context to the second case since he was actually on that case. So we'll start with this first case this morning. Who's going to be presenting this case, or am I presenting it, Michelle? I think we lost Michelle.
Nope, I'm here. I'm sorry. I forgot that I was on mute. I can present it.
Okay. All right. Well, step 1 here is I'm going to lose all you guys because I'm going to go into sharing mode here. All right. So first up, who's our panel today? Who are the docs that jumped on? I know I saw Asa. I think I saw Matt Levy. I think I saw Eric jump on. So let's run through who sort of our experts are. And a little bit of who you are.
You want us to introduce, sorry, Sam, you want us to introduce ourselves? I didn't quite catch that.
Please.
Okay, yep, I'll start. So Asa Margolis, medical director with the Lifeline Critical Care Transport Program, also assistant professor in the Department of Emergency Medicine at Johns Hopkins. Wear a few additional hats. Many of those seem to end up with Matt Levy in one way or another. So I work with Dr. Levy over at Howard County as the associate medical director. I'm also the fellowship director of the EMS fellowship here at Johns Hopkins. And again, happy to be part of this. I think this is a great opportunity for us to continue to collaborate and share very, very interesting cases. So thank you to all who continue to push this forward.
Matt, why don't you go next?
Okay, great. Good morning, everybody. It's a little loud where I'm at, so I have you guys muted. Matt Levy, one of the other faculty at Hopkins. I'm an associate professor of emergency medicine and one of the Lifeline medical control physicians and associate medical directors. Also wear a couple other hats, as Asa alluded to, doing lots of fun EMS things in and around the Baltimore metro area. Happy to be here and looking forward to the discussion. So thanks, Sam.
Yep. Eric.
Hey guys, Eric Garfinkel, one of the medical directors for Lifeline, one of the EMS physicians at Hopkins, and happy to be here. Also have some other hats as well, but those are probably the most relevant for today.
And then Kate, I think, right? I think that's everybody.
Yeah, hey, can you guys hear me all right? Okay. My name is Kate Heck. I'm the EMS fellow this year for Johns Hopkins EMS Fellowship Program. I have a former life as a paramedic doing mass gathering and standby EMS back in Chicago. A little bit of critical care experience as well. Did some emergency medicine residency training in Washington, D.C. And also I'm involved in the Army National Guard as a flight surgeon for District of Columbia. And so I'm the medical oversight for their medevac program. So happy to join the discussion today.
Awesome, thanks for joining us. I think that's everybody. Did I forget any? Did any of the other providers hop on? Not that I'm seeing. So, all right, well, we'll move on to this first case because I think we're gonna have a lot of discussion. So I wanna kind of keep this moving. So if I can make my PowerPoint work. Our first case is a type A dissection, and I'll let Michelle go ahead and give us the rundown on sort of how the case started and then how it progressed.
All right, so this was a 65-year-old gentleman who was over at Sinai. We actually went as a dual nurse crew on this one instead of having the traditional EMT medic and nurse. Patient had a AAA that was dissecting. He was at home moving a bookcase when he had an acute onset of abdominal pain that radiated through to the chest. He yelled out. When the family came and found him, they saw that he was down on all fours, then rolled over onto his back. He was complaining about seeing spots and then became unresponsive. When EMS arrived on scene, the patient had agonal breathing. He was also decorticate posturing and had dilated sluggish pupils and cool extremities. He was intubated in the field and taken over to the ER. They did discover that he had a large type A dissection with extension into the carotids and into iliac vessels, including the subclavian. So whole kit and caboodle. So when they got him there, they started doing, let's see, on the slide, what did I have written?
Hey, Michelle, I'm going to stop you right there.
Yep.
Real fast. If I can make my. So from the docs that are on, what do you want me thinking as I'm headed out the door on a dispatch like this? And I know that Michelle kind of got further into the details of the case, but just based on that dispatch, what do you want us thinking as crew as we walk out the door?
So I guess I can start. So it's all about blood pressure, either high or low. Blood pressure management is pretty key for this to, again, if it's too high, avoid ongoing propagation of the tear, but also want to make sure that this seems like a very significant dissection and that the patient obviously isn't hemorrhaging. And in that case, it's my view that we treat them like a hypotensive resuscitation, like a trauma patient. So we should also be thinking about blood and resuscitation of the hypotensive patient, just as we are with blood pressure control in the case of the patient is hypertensive. I could stop there and let others pop in as well.
Yeah, the first thing that came to my mind was heart rate and blood pressure control. I know at Lifeline, this has been a point of emphasis for the past year or so, because it is so difficult to get these patients to roll. And then the second thing I would want to emphasize is that generally these patients will be going to the OR because this is a surgical emergency, and time is kind of the essence here. The longer you take, the more dead end organ perfusion, and the longer and less likely you are to get a successful repair.
Kat, Matt, anything? Kate, Matt, sorry.
So this is Matt. I mean, I would agree with the general sentiment. I think that that these patients are some of the most critically ill and complex that we will transfer for a lot of different reasons. Having a plan and having a backup plan is really important. I think, agreeing with what Asa and Eric already said, I would add, wanting to know things like, what is our access? Has anyone put a probe on their chest yet? We can talk about why that is in a second. But knowing what's going to happen next if this person decompensates and being ready for it is probably the most important thing. I don't know if anyone's ever seen one of these folks dissect out and arrest before you, but once they arrest, it's very hard to get them back, even if they're on the table. So what is our plan and what are we doing about it? And everything from blood products, like Asa said, to blood pressure control is really important. And then the last piece I would mention is trying to get the history on this as well, because we do see an interesting phenomenon, which is there are some people who walk around with a known dissection, although typically not a type A. We'll talk about that later. But is this the index presentation, or is this somebody who has this known history that has worsened is also important. That's all I have. Back to you guys.
Yeah, hey, this is Kate here. So just kind of echo the same things that the other docs have mentioned. And like Dr. Levy just mentioned, some dissection cases can be somewhat subtle in the presentation. And so oftentimes it's, if you have the information, that's really helpful, but you might not always know, right? You might have like undifferentiated abdominal pain, chest pain, and sort of keeping this on your mind, although more so in the critical care world, you probably have the diagnosis already made at a sending facility before, that patient is transferred to, the appropriate surgical facility where they can do the repair. And so I think that can be, one of the pitfalls in these types of cases. But again, anticipating things getting worse, knowing that it's not something that you can fix, but can really only temporize in the meantime, and figuring out what your plan is going to be for, if that dissection were to proceed and cause a massive rupture and resuscitate them appropriately.
Perfect. Thanks, guys. So Michelle, I'll let you you hit on some of this stuff, but this was essentially your story that you got when you got there, correct?
That's correct.
So I think you got on most of this. It looks like you got our side in the field, which was sort of surprising to me given where he went, because not a lot of folks around here have RSI, particularly around the sending facility. But good job for EMS for getting them our side, get them to the outlying facility, and they find this. This is sort of what we get at the outlying facility, correct?
Yes.
Okay.
All right, so you had the
So-
type A dissection that started at the aortic root, extended all the way down into the iliac vessels, upwards into the common carotids, as well as the subclavian. And they also saw that he had a pericardial effusion on there as well.
Great, and then you can kind of see the labs there. I wanted to sort of hit on some of these labs. So INR of 3, badness in a patient like this, right? So that's definitely something that jumped out at me when we went through this case, Michelle, and that lactate of 8. The other thing that I found interesting was some of the profound metabolic acidosis that this patient had, particularly the fact that they burned up a lot of their bicarb. That bicarb of 12 really sort of jumped out at me. So it almost made it seem like this had been an ongoing thing for a little bit. They had been in kind of that end organ perfusion, metabolic acidosis for a bit. As far as the panel goes, is that sort of, am I on the right track with that thought process, kind of looking at these labs?
I think to
So this is Matt. I'll jump in. Oh, okay, Lisa.
no, I think to Dr. Garfinkel's point, it suggests hypoperfusion. You see the troponemia, you see the elevated lactate. Again, all of that picture suggests stress. It suggests hypoperfusion. I'm a little surprised that the renal function is what it is, but again, I'm sure over time that renal function will also worsen. But again, that's what the general picture tells me. As far as the INR, back in the patient's past medical history, what would cause them to be on warfarin, or are they not?
He actually has no past medical history on file.
Okay. Because he
So
doesn't
kind of a fuzzy
major
picture,
hepatic
right?
issues. Say it again, Sam.
Kind of a fuzzy picture, like why the INR of 3? It's just one of those things that's like kind of makes you cock your head sideways like the RCA dog.
Yeah, like I don't have LFTs, so I don't know if he has just profound liver dysfunction, or he has a really, really bad diet and profound liver dysfunction. But that, just obviously is a point that's interesting to me, given his unknown past medical history, or at least what was documented initially.
Sure. Matt, what did you have?
Yeah. No.
Hey, Matt, we're losing you a little bit. Hey, Eric, you want to hop in? Or
Yeah, go ahead.
Kate?
I don't know what Matt was going to say, but I did want to bring up one point, was that this pericardial effusion, you're understating it a little bit. Unless you know that that's been there in the past, that is blood. That is concerning for impending rupture and possible tamponade. So that is a very, very poor prognosis and sign that you could decompensate and route pretty quickly.
Can you guys hear me now?
Yep, gotcha.
Yeah, there we go, Matt.
Okay, yeah, thanks, Eric, for jumping in. That's exactly where I was going with that. Is please don't underestimate or you'll see the report. It'll say tracer small pericardial effusion. That don't let the size confuse you. As Eric said, the guy with coags like that, with this kind of history, is bleeding into his pericardium. What I was trying to say before my phone cut out was we need to know this guy's vital signs right now, and we need to see the trend on those vitals, because that's going to tell a lot about what's going on with him too. So the imaging and the labs are great, but let's also make sure we have a sense as to what his vitals are and where he's going at this point.
Thanks for that segue, Matt. They were garbage. There we go. So Michelle, you want to give us a little bit of a rundown here?
Sure. So we got on scene and the vitals are as you see on the monitor there. Everybody was in that room trying to figure out how they could help the patient. They had him hooked up on the ventilator. So the 2 nurses and the EMT assumed care of the patient, did the normal assessment and whatnot, tried to adjust ventilator settings to try to fix the SpO2, as it was 78 when we walked in the room. Also, he just got a dose of labetalol because his original heart rate was 100. So they were able to get it down to 80 with the dose of labetalol. However, then you're managing the blood pressure as well. So that was a little bit of a sticky situation. We wound up doing fluid boluses, and we had called back to the CCRU a couple times to figure out, we were talking to Dan Hasse to figure out what his treatment plan was going to be for this patient, whether he wanted us to try to do other medications to adjunct that or just to continue on with the fluids. So this was trying to stabilize the patient. He was not able to get surgical repair at Sinai because the cardiothoracic surgeon was actually in the OR with another case at the time. So we were trying to get all that stuff straightened out to try to get a patient that was stable enough, stable, quote unquote, for transport.
Hey, Michelle, this is Matt Levy. Can I ask a quick question?
Sure, go ahead.
Was anyone hanging blood, or had they called for blood at this point? I'm just curious.
They had not called for any blood.
Hi, I'm Victoria. I was the other nurse on the call, actually. That was something we brought up to Dan Hasse in the CCRU, asking for blood. And unfortunately, at Sinai, the time it would take for them to get blood to us was more than we would even take to transport back. So the plan was to try and, like Michelle said, like adjunct as best as we could with what we had, because unfortunately we didn't have much. Because basically we decided the patient needed an OR and now, and that's kind of what he needed and what we needed to get him to as quickly as possible.
Yeah, that makes a ton of sense. The follow-on question to that was there a discussion at the bedside prior to your arrival or when you guys arrived with reversing this patient? Because, clearly needs volume, needs blood, also needs to, have his coags reversed, particularly because of the pericardial effusion, which is essentially blood at this point. Is there any discussion about that as well, or is that just sort of glossed over given all the rest that was going on?
I believe that was glossed over. I believe we found that information out after we had already gotten back to university.
Yep, understood. Thanks.
Was there a thought to why the patient was hypoxic? This is concerning. This makes me think he's bleeding with the hypotension, bleeding into his into the pleural space.
There was no reason for him to be hypoxic. His color was definitely crap. So
he's on FiO2 of 100%, right?
Yes.
I think we also were concerned. We were having trouble even getting a pulse ox originally as well. He was so poorly perfused that I think we were on like our third or fourth pulse ox to even get an accurate reading as well. So that was another little hiccup that we had.
Yeah, that's a very fair point. Is that an A-line pressure, guys, or is that cuff pressure on the bottom there? I can't tell from the screen.
These were all cuff pressures.
Okay, that was my next question. Okay, thank you.
All right, so you guys did your best to get them kind of pseudo stabilized as much as we can stabilize some of these profoundly sick patients. And this is what your transport looked like. Michelle, and I'm sorry I didn't catch the other nurse's name. Why don't you guys give us a feel for like sort of what happened in the, what are we looking at? Probably a 15-minute run, 15, 20-ish minute run from descending to the CCRU.
Thereabouts, yeah. So we continued with doing our fluid boluses. And basically, as soon as we got the ambulance into drive and got off the driveway, he went into PEA arrest. So we immediately started CPR. We're running through our ACLS algorithm. And we did call back to the CCRU and let them know what was going on. We left the patient on the ventilator while we were doing compressions because just didn't have enough hands. Would have been nice to grow octopus arms, but we didn't have that luxury right then. So we did do one round of epi and we were able to achieve ROSC afterwards. When we got to university, the CCRU team met us in the ambo bay with a Lucas device so that way they can assist with trying to get us upstairs. Anything you wanted to add, Tori?
Nope, I think that pretty much sums it up.
Just for my curiosity, how much fluid were you guys in at this point? How much fluid had you guys given?
I don't recall off the top of my head how much he had gotten there.
One bag.
I know that we had 2 bags going wide open. I'm sorry?
1 bag, 2 bags, half a bag, like ballpark. Couple bags.
Probably half a bag for us. We had them on pressure bags.
Sure. Okay. Matt, what you got?
So this is really, really interesting. First of all, you guys, it sounds like you did a hell of a great job with a really super sick patient that even inside the walls of a hospital, people are, like not sure how to best manage him from where it sounds like where you're coming from. I find it really interesting and noteworthy that you got Rosk on him, because that to me tells me that the etiology of his arrest was not the evolution of his vascular catastrophe, right? It was not the evolution of his aorta finally splitting apart and dumping into his pericardium or into any number of spaces. And it makes me wonder, what was the etiology of the arrest? Was it actually truly a hypoxic arrest because it was epi-responsive? So I'm just curious if there was any more talk about that that you could share, or if I'm jumping ahead, I'll stop. But I think it is an interesting.
No, I actually agree with you. I think I even remember saying this to Dr. Hasse on the phone, that we were concerned him even making it the way back. Should we even transport? And like I said earlier, I think the agreement was he wasn't going to get what he needed there, and what he needed was an OR at Maryland. And so we transported in unideal conditions, hoping that we could get him there. And when he arrested, I think we both were worried we weren't going to get him back, and we're pretty shocked that we did as well, in such a quick manner. So I still don't know what caused it. But I agree, I don't know if it was not his continuing dissection.
This is a pretty remarkable case. I mean, I don't know how it ends, but I was just like feeling anxious, just you guys just telling me the case with the vital signs. It's like, this guy's not going to last much longer. But ultimately, I mean, I think that you got to transport him, because you have to get to the operating room. You have to get to definitive therapy. And if he dies, then, you're doing the best you can. So, wow, great job getting Ross.
Yeah, I agree with what's been said so far. And I think, on our side, if we had this case on the Lifeline side, we would have made the same decision. These outlying hospitals call us because it has generally exceeded their ability to care for the patient. They are calling us for help. And yeah, sure, we can certainly help at the bedside, and we often do. But being able to take the patient out of there and get them possibly what they need is, I think, where it's at. So yeah, I know you probably went back and forth a bunch of times. Should we not? We don't want the patient to die in the back of the ambulance. But I think these are the patients that still need to go. And I think you would only really recognize that having done critical care transport, right? If you presented this case to people that aren't used to this field and this type of work, this is an unstable patient. You can't transport an unstable patient out of a hospital. Are you nuts? But this is what is unique to the line of work that we do. So that's one. My other comment is going to be somewhat more controversial to put out there, and we may discuss this later, so then we can hold it. But we're fluid resuscitating the patient with crystalloid, and what we need is obviously blood and blood products. And by resuscitating with crystalloid, we are in theory diluting clotting factors. We're diluting oxygen carrying capacity of the hemoglobin, with the goal of giving fluid, obviously, to raise the person's blood pressure. Was there any discussion? I'd be curious what the other physicians think about maybe not giving fluid in this case and putting the patient on a pressor instead. Because
you're jumping ahead on me.
Obviously, there's two sides to the story, right? There may be a reason why we're giving volume here, for the pericardial effusion potentially to give preload, which a vasoactive agent won't do. But maybe giving, crystalloids in this case is diluting, and that has a negative effect. So I'd be curious to see what the other physicians, nurses, anybody out there thinks about that back and forth between vasoactive versus crystalloid.
Actually, on scene at Sinai, I had suggested, did we want to try to give any pressors to help out with that? But the feedback that I was getting from the physician on scene, as well as the CCRU attending, is that's just going to make him bleed faster. It's going to put more pressure on the area. So we were going to treat with the fluids as opposed to pressors.
Point to note. Certainly that's the conventional teaching, right? That's the theory, and they're not wrong in saying that. Eric, I think I interrupted you. Go ahead, man.
No, I think you're going to say what I was going to say. So go ahead. You'll say it better.
At this point, we have a person who's actively trying to die in front of us, and we have to do something. And doing something is better than nothing. And so I think starting a I'd be interesting. So yes, I actually would consider starting a presser at this point, and that was actually going to transcend to my next discussion of which presser would you start, because this is a guy who might actually benefit more from an epi drip than a norepi drip if we're going to go that route. But
we hold this discussion for like 2 slides?
Sure. We're ruining Sam's Monday. Yeah, Sam, we'll hold.
Killing me. You're ruining my flow.
Sam, we will not speak unless asked to speak from now on. Go.
I'm joking. You guys know I'm joking, but you're playing right into some of the points that I want to get to on
Dr. Launer's on
slides down the road here. So we'll finish up the transport. CCRU team meets you guys, right? And you guys transition up to the CCRU, correct?
Yep, that's correct. When we got up to the CCRU, they did a bedside echo, and they actually determined that they were going to be doing a pericardiocentesis with drain at the bedside, and they were able to remove 400 cc's of dark red blood. After that, he did have improvement in his hemodynamics with resolution of the pericardial effusion. However, he didn't really have too much left neurologically afterwards, so they wound up having to withdraw care. But a pericardial tamponade is probably the reason why he arrested in the transport.
All right, perfect. So we're going to move on to sort of, this is the bulk of our discussion here, sort of expectations and considerations for this transport. So the first thing I want to kind of talk about is, like, you guys probably went out the door expecting to sort of run down the type A dissection pathway. And when you got there, you had to shift gears. And I kind of want to talk about the concept of clinical momentum, or sort of being locked in on, this is what I thought I was going for, and you have to sort of shift your mindset rapidly. Do you think that was something that it took you guys a second to go, okay, well, wait, I was going to try and start the cardipine drip, and I was going to try and have to deal with high blood pressure, or lowering their blood pressure and lowering their heart rate, and you saw Sinai gave labetalol, right? You're taking compensatory mechanism away from a hypotensive patient. Do you think that caused anything, or not necessarily this case, but just in general, like, do we see that as something that happens?
Definitely. When you hear that you're going to go to a dissection, you're going to be pulling nicardipine or something with you to take, because if you have to start anything for blood pressure management. But I think when we got to bedside, we just doing our 360, we could see that the patient was beyond that, and their coloring, their vital signs and all, we were managing more of a shock type scenario than we were actually the dissection.
Sure, perfect. And then once you sort of, and the docs kind of talked about this, but once you make that shift, what are the goals of care? Is it like you guys talked about, essentially this is a hemorrhaging patient at that point? And how does it change that it's a hemorrhaging patient versus the new suspicion that it's now a pericardial tamponade?
We were kind of treating for the hemorrhaging patient, but at the same time, with the tamponade, when you're doing the fluids, that's typically what the primary treatment's going to be, unless you can actually do the pericardiocentesis or the window to get the fluid out of there. You want to try to get as much contraction as you can to get the blood flow. So we were going more with that than we were with the actual bleeding. So it's a little bit of both. Just had to figure out which direction to start at and meet him at the middle, just so we had a viable patient to get him the best chance we had.
Sure. How do we think, as the panel, how best do we differentiate where that shock's coming from without an ultrasound probe? And I definitely want to talk about that, as is this the perfect example for the argument for focus in the EMS environment?
I know ASA is very pro ultrasound. I do think this would be a great use of the ultrasound, but I don't know necessarily if things would have changed, if your approach would have changed too much in here without being able to do pericardiocentesis, which kind of actually brought up a question I had. Does anyone know of any EMS agencies or critical care agencies that perform pericardiocentesis? Because ultimately it's one of those things that you really, you can't you cannot fix this without taking that fluid out. So I'm just curious if anyone else knows anywhere across the country that does this in a non-physician capacity.
I know that we did on the aircraft that when I was with the University of Maryland, we trained for it with the Express Care 1 team. I don't think anybody actually ever did it.
Yeah.
But yeah, there's a lot of flight programs that it's in their scope.
Interesting.
And
Interesting.
in their training is their procural. I mean, it's like one of those last ditch efforts. The patient arrested, you can't make them any more dead. Let's stick a needle in their heart.
Yeah. And for a patient like this that had that amount of fluid, like it would be a fairly straightforward one to do if you've trained on it before. Obviously, you're not going to do it, never trained on it, but curious.
Yeah. So there's a couple things. I don't know if there's time just to comment on this here. Sam, I don't want to burst your bubble. I've been waiting.
No, go.
We know it's reminiscent of these echo panel battles, you know, where we wait. But so a couple things. I think expectations is a great heading for this particular slide, because you know I am so frustrated sometimes with, you know, anytime we have a bad outcome, this leads to this issue of risk. Like, well, why are you transporting unstable patients? And you said earlier that you know, it's very difficult, people don't understand, and I still think that's very correct. So I think we have to have a very careful conversation with not only the sending but the receiving facilities about what we think happens en route. Because remember, you know, these ruptured or these, you know, catastrophic incidents, there's certainly a high probability of deterioration. And as we've seen, and in this case, you know, ultimately the patient died from, you know, his aortic dissection, his comorbidities. And I think that also has to be able to inform efforts on the back end, meaning, you know, what do we expect to happen when we put this patient who is actively hemorrhaging to death with a, you know, pericardial tamponade from an aortic dissection in either an aircraft or an ambulance? So that's one thing. You know, number two, I think we also have to fall back on some mechanisms, because this patient, as Michelle mentioned, needed an OR. And I think we have to be very careful with invasive stuff. And we do teach pericardial centesis. My problem is, you know, for pericardial centesis, it's from an aortic dissection. You know, when do you stop? And so are you using a spinal needle? Do you put a window in there? And, you know, with ultrasound, are you going to make sure that, you know, are we going to say that, are we going to say that we have hypotension due to the pericardial tamponade? So I think we have to also fall back on certain
here to watch it, or you
So number one, if you have a patient like this, I think in the setting of hypotension due to shock or due to aortic dissection, it should be hemorrhage until proven otherwise, which is why we've been able to use cases like this to get blood actually stocked at our base. That has been a huge issue for us, and we rely on blood either in the TRU, the CCRU, or also the sending facility. And I think we'd all agree that if you have hypotension due to the setting of shock or dissection, it's always hemorrhagic shock until proven otherwise, because it gets very difficult to go through this whole diagnostic burden, right? And I agree with Dr. Garfinkel that what do you do with the ultrasound? You know, once you find that there is, I mean, where do you start, right? What if this person is ruptured in the perineum or the retroperitoneum? Sometimes it can be very difficult. I think ultrasound can inform your diagnosis, and it can certainly make procedures safe. But I also, it begs the question of, you know, how much do we do when you have a patient who is, you know, at the extremes of life or at the extremes of physiology, and what can we do to temporize? So a lot of really good discussion about this case. The bottom line is, you know, we were able to complete the mission to get this patient some time with his, you know, family members, but ultimately it's this, you know, a non-survivable kind of injury. So lots of good discussion.
Yeah, I mean, this was definitely something that I wanted to talk about, honestly, with the second case, but I think it makes sense even here, like both these cases fit that bill. I'd like the panel to unpack the idea of the too unstable to transport. Is that a thing? Is there ever a patient that is too unstable to transport? And I know, Dr. Lohner, you and I have talked about this on the echo panels, but I would be interested to hear the rest of the panel's thoughts on at what point does a patient become too unstable to transport?
I guess I could start with that. I was going to one other thing with respect to the physiology underlying shock in this case. Completely agree with Dr. Lohner, 100%. Hypovolemia, hypovolemic shock until proven otherwise. The other interesting thing here is whether you're saying it's hypovolemia or an obstructive picture secondary to a tamponade, they need preload. Either way, they need preload. So preload is the way to go. both ways in this case. Ideally, it would be with something blood and blood products, but crystalloid is what you have, and that's what you use. Now, on to your second question. Rarely do I think there is a patient that is too unstable to transport if they are not already in cardiac arrest. The patient who is in cardiac arrest, for me, meets generally the criteria of too unstable to transport, because then we are not delivering a viable patient. There are some exceptions to that, that one day hopefully we'll get into around this region, which is maybe some ECLS, refractory VF on a Lucas to cannulate for ECMO in the cath lab, maybe depending on what our transport times are. But generally speaking, in arrest qualifies to me as unable to deliver a salvageable patient. The other patient population who I would include in this would be the OB patient. So a patient who is about ready to deliver, who I think may be delivering in the back of the ambulance or the aircraft. Particularly in the aircraft, you have no access to the patient's lower half. So if they were to deliver in the air, that would be a very dangerous situation. Additionally, if you're taking a patient from Southern Maryland and you have a prolonged transport time, it would be my inclination to deliver the patient where they are, send the NICU team. We can certainly, if it's imminent, have our team remain at the bedside for additional hands, additional expertise, and then to transport the mother, and then ultimately the neonate and the NICU transport team as well. So that would be the other sort of patient that I would consider as potentially too unstable for transport.
Hey guys, this is Ruben. Came on a little late to the call, but I got the gist of what's going on. I have a couple points of contention in terms of, the ultrasound and too sick to transport. And I think if we're, and appropriately so, saying that this patient cannot stay where they're at and they're not too sick to transfer, then we should be able to mitigate the complications in transfer, right? So should we not be able to do an ultrasound program and do a pericardiocentesis? And to Dr. Launer's point in terms of what's the stopping point, I don't know. They may need one or two needles in the heart. I really don't know, but how else is this patient going to survive? The patient didn't hemorrhage like into the belly. They hemorrhaged about 400 cc's around their heart. We know that rapid amount of fluid is deadly for someone who's not, used to that. So, they may need one or two rounds before they get to the operating room. But how can we say that they're not too sick to transport, but we can't intervene on the underlying etiology in some beneficial way?
This is Matt. Maybe I could follow on
Thanks,
to
Ruben.
that
Yeah,
for
I
one
think
second, Ruben. Okay, Tim.
Yeah, go for it. Go for it.
All I was going
Go
to
for
say
it.
is this philosophical debate about too sick to transport has been around for as long as we've been transporting people. Ultimately, I happen to agree with most of what Asa said, not all of what Asa said and how he said it. Unless they're actively in arrest or imminently about to deliver, I think our paradigm should be, we are going to complete this transport. My one pet peeve I would share with the group has been when a sending or receiving physician decides they're too sick to transport. That I believe that expertise lies with the team, with the interfacility transport team, who is the most skilled and most capable of doing that. And so I would just contextualize it that way and say, I think if we feel they're too sick, then that means something too, and especially with consultation through medical direction. That's all I was going to add.
Yeah, let me so again, I agree. I think this issue of too sick to transport, we've said we don't really have this policy, but yet this comes up literally every day at this program. And I'm continually humbled by the sick patients that we have to move, not to mention COVID ARDS. But let me just reiterate, I think we have to also have buy-in from other people. Like, it's fine for medical directors and transport teams to say this, but I can't tell you how my risk queue grows every day when we decide, hey, let's take this person for ECMO cannulation or ECMO evaluation who's on APRV at an FiO2 100%, and they've got no, they can't maximize the SpO2. They come over here and have a bad outcome. And the default is always, well, what happened in transport? Well, you know what? We're the ones that are taking these really sick patients. So I think this is something where we have to socialize this idea amongst our risk managers. And as Matt said, particularly amongst our setting and receiving facilities, because this is expertise that has to lie with the transport team. But once we decide to do this, and once we say, hey, let's complete the mission, we also have to be tolerant of outcomes such as this, meaning where, patients decompensate because we're taking people who are sick. Now, to Ruben's point, and this can get into a little bit of a philosophical debate in terms of procedures. We also have to be mindful of the limits of transport. So in other words, in a patient who is having an aortic dissection who is hypotensive, we're assuming that we know that the pericardial tamponade is the etiology of the patient's shock. And I would just say that we have to make sure that our crews are extremely well prepared for these contingencies, because if we also know, transport, in my opinion, is also definitive treatment, right? And if we know that the patient needs an operating room, I think we get into just a difficult territory where we're asking our crews to take upon themselves the burden of this diagnostic and therapeutic plan. So I am certainly not opposed. As a matter of fact, we have that in our protocols. It's just, this is one of those things where, the same thing where you're talking about putting in a chest tube for a hemothorax that's temporized in an outside facility. I think we have to have a healthy discussion of risk benefits, because these patients are so sick, and sometimes it's very difficult to deal with the downstream complications of the procedure. No easy answers.
So I think we could probably go round and round about this, and like you said, Matt, this has been a philosophical debate as long as ambulances and helicopters have existed. So I want to push off to a couple of the other the points that we wanted to hit on, and one of which that you brought up previously, Matt, was vasopressors in this patient. And I want to throw two questions out there. What is the vasopressor of choice in this patient? And then if I wanted to temporize them with a push dose vasopressor, what does that look like? Is it epi? Is it neo? Those tend to be the two push dose pressors that we tend to see and are in most people's protocols. And then if I'm going to start a drip, is it levo? Is it epi? Is it vaso? Is it phenylephrine? Please, nobody say it's phenylephrine. But that's kind of what I want to throw out to the panel is, like, if we're going to go to a vasopressor in this patient, what is it?
I love this question. I don't know. Anybody else want to go first?
You're talking, Asa, go.
I think it depends for this patient on a couple of things. One, we have two different parameters that we're trying to optimize. Generally speaking, dissection patient, heart rate and blood pressure. So I think my vasoactive agent is going to somewhat depend upon what my heart rate is in this individual. Because if I'm just getting better blood pressure, but increasing their heart rate, I'm not quite sure that's going to be very helpful to me. So while, phenylephrine is never my first choice, with the exception of LVOT obstruction, maybe I'm not going to get any heart rate increase. And I can even get a little bit of reflex bradycardia with, the pure alpha. We tend to say epinephrine in this case, but, do I want all of that beta? Maybe not. Vasopressin actually may be the go-to. The only unfortunate thing with vasopressin is not titratable. We could certainly turn it on at 0.04, or now people are using it at 0.03, but either way, and see where that gets us. There is some literature that suggests that it's helpful in the massively GI bleeding patient. Massively GI, I just looked at Dr. Waller's comment. But, I would even consider vaso in this case. Would have to again look at to see what the heart rate is. But that's, that would be my go-to.
Sorry, my computer's losing its mind. Okay. Anybody else got any thoughts?
It's interesting.
Yeah,
it's
this is
almost.
Kate.
Sorry, go.
Oh.
No,
Yeah,
go ahead, Kate.
so,
Go ahead.
yeah, thanks, Ruben. So, I think also, like, what's like the risk benefit here, with the patient with this short transport time, if you were to kind of expand scope into having an ultrasound at the bedside and pericardiocentesis kit, depending on the patient's body habitus and how easy or difficult it is to get to that fluid pocket and get the, relieve some of that obstructive shock, versus getting them ultimately to the OR that they need. How long are you willing to spend trying to do that procedure versus, maybe just trying to support with preload or some pressure, vasopressor support. Because if I saw it correctly, the transport time for this patient was, you know, maybe on the road about 10 minutes or so. So just happy to kind of, you know, what are some people's thoughts about that?
So I call you, what vasopressor you want me hanging? Epi? My thought would be Epi.
Right. No, I guess more I'm trying to, my question is more like, what is the, how long are you willing to, if you had ability to do pericardiocentesis and, you know, maybe you weren't entirely facile with that procedure, how long would you be willing to spend at the sending facility or, you know, in the ambulance to try and stop, right? And I don't know that this is a procedure I would probably do like on the move. I don't know, maybe some people would, right? But would you spend trying to do that versus just ultimately getting them to the OR that they need?
I know, I think it's a risk for me. It's like a risk benefit. Like how far out am I? And I might try it once if I've got it, and I feel like this is big enough that it's caused this hypertension, and I'm convinced myself that this is the etiology for my shock. I'd probably try once and see if I get it, and then I'd probably go to vasopressors and diesel, like or Jet A.
To go back to the vasopressor conversation for a moment, I don't know how much a vasopressor is going to help, because we don't have, I mean, the issue is not vasodilatation, it's not vasoplegia. Really, you have an obstructive process, you have lack of intravascular volume. So how much is a vasopressor actually going to help, regardless of what vasopressor you have? So I don't really know that the choice of vasopressor makes much of a difference, rather than using our, the best vasopressor we have, which is blood.
Yeah, I'm glad I think it's really important to just focus on the big picture and stuff like this, and sometimes this is the big pitfall of critical care transport is we get lost in some of the weeds, and it's not that we can't navigate through weeds. Sometimes there's no good answer, right? Because our job is to get them to definitive care, and sometimes they require some critical care interventions to get there. And those are some overriding things that need to guide this. As Sam said, maybe he tried once or twice with a needle or with a central line kit, but the overall synthesis has to be, we have to get them to a place where they're capable of providing with the definitive care, with all the diagnostics. So I think these questions are exactly where we should be. We operate on the area where, there are no answers and no protocols for stuff like this. And I think the right answer to these questions is clinically dependent, right? It depends on what your patient situation is, what your crew configuration is, how sick the patient is, whether you have blood. These are all dynamic things, which makes it very difficult to protocolize.
The other thing that
we could have opened the chest. I mean, finger thoracoscopy. We could have done that and then got a dry tap. I mean, who knows, right? It's tough.
The other question that I had looking at this case, and this is just because I'm a vent nerd, and so I picked up on the ventilator stuff. This patient was profoundly acidotic, and I wonder if more minute ventilation potentially would have. I wonder if it was kind of a combination of RV failure as a result of the pericardial effusion, coupled with essentially a metabolic acidosis, vasodilation as a result of the metabolic acidosis. So I know that the minute ventilation was a little on the low end, but I also think that this is a tricky situation, because as you potentially drive up their minute ventilation, you're going to be driving up anthoracic pressure, which is just going to compound the whole issue. So I'd be interested to hear the group's thoughts on sort of how we find that fine line with the ventilator and blowing off enough CO2 to keep them out of metabolic acidosis, because this guy was in a metabolic acidosis because of end organ perfusion, is my guess. Over a long period of time, he had burned up a bunch of his bicarb. So how do we find that fine line?
And I mean, I think you could certainly tweak your ventilator. I would put the worsening metabolic acidosis probably 3 or 4 on the list of why this patient expired, but certainly a contributing factor. If you can, change your minute, increase your minute ventilation, if you can increase your rate, and you could appropriately decrease your I time, and you can make sure they're having enough time for exhalation, and you're not giving them large tidal volumes. So, right, changing it with the respiratory rate component rather than the tidal volume component. Yeah, I mean, maybe you would be able to get away with increasing the minute ventilation and not necessarily have a negative effect, as much of a negative effect on their intrathoracic pressure. But if you do so, I think you have to be thoughtful on how you affect the minute ventilation through the respiratory rate rather than the tidal volume, and making sure their I time is changed appropriately.
Good deal. Anybody else thoughts on that? All right. Anything else anybody wants to add on this case? We'll keep moving. All right, so just a little bit of follow-up. They did get the patient to the CCRU. CT surgery, did an emergent cardiac ultrasound, did a paracentesis, or pericardocentesis, took 400 off. And I believe, Michelle, the patient still expired. Yeah, they made him comfort care, correct?
That's correct, yes.
Yeah.
But the wife was able to be at the bedside when all that took place. So if nothing else, we helped out the family.
Yeah, perfect. This was a great case. You guys did a phenomenal job on this. This is a really tough one. It's one of those like short transports where it's like, how much do you do? How much don't you do? And to Kate's point, like, do you just get them where they need to go, or do you try and fix them en route? So I think it's a tough decision. So great job. So we'll move on to the second case here. This is a very unique case, and I'm not so sure cardiogenic or hemorrhagic shock gives it does it justice. So we'll dig into that. Michelle, are you going to present this, or is there somebody else that's going to present this one?
Actually, Devin is going to be presenting this one. He was the medic on this call.
Okay. All right, so this is the dispatch that they get going out the door. Devin, tell me if this doesn't do justice on like what you guys got going out the door. Did you have more of the story, or was this basically what you got? Like, hey, get out the door.
For the most part, this is basically what we got. The only additional information that we had was that flight was already on scene.
Okay.
The other thing that they told us is basically that they were sending us because they were running out of blood. And they couldn't continue giving the patient blood any longer.
Okay.
But that's basically the gist of what we got. We did know that the patient had delivered a stillborn, and that the patient had arrested multiple times, as well as gone into surgery roughly twice.
Yeah, and you also knew you were taking 3 physicians with you. So like kind of added an extra layer of stuff.
Correct.
Okay. All right, so I think based on that dispatch, sort of what does the panel want us thinking as we're going out the door? This is sort of how I want to frame this stuff. And this is a little bit of a difficult one to use that for, because like I said, there was a pseudo go team that sort of went out the door with them with 3 physicians. But if I get dispatched on this, what do you want me thinking as I go out the door? What are sort of priorities for DIC? And hemorrhagic shock secondary to like uterine to OB causes?
First of all, I want to know who this go team is that went out the door.
It was Ben, Sam Galvana, who I don't know if you know from.
Oh, I know
Hopkins, Sam,
Mm-hmm.
and then Liz Powell, who's one of the CCRU docs. Who's
Yeah.
also,
Yeah. Strong team.
Yeah.
A strong team.
Yeah.
Chad, I am coming with you on your next call. Dr. Lona, I'm in. Actually, you're to get all of us. Garfinkel, Cosa, everybody's coming. So whether it's from sepsis or from what we'll probably see here is some sort of, OB catastrophe. DIC is pretty much DIC. And when you get to DIC, you're thinking down the same pathway in terms of a consumptive coagulopathy. And with your consumptive coagulopathy, you're obviously having to monitor a number of parameters in near real time in order to best sort of effectively manage the patient, while you're also trying to figure out what the underlying issue is. It's kind of like sepsis in source control. If I have a big old, I don't know, neck fash that I'm not taking in the OR, I can give all the antibiotics in the world that I want, not going to fix the patient. You have to be able to get at what the underlying issue is that has resulted in DIC as well. So I would like you to take the blood bank and the lab with you, if that's such a thing, to be able to, analyze the D-dimers and fibrinogens and platelets and, your PTs and PTTs.
So I'm taking my mobile tag machine.
Yeah, you're taking your mobile tag machine, you're taking your blood bank. But no, honestly, it's about resuscitation, it's about balanced resuscitation, and it's about trying to get to the underlying etiology.
So there's a little bit of background here too. It's interesting, and this is where this is such a great case to talk about, because I tried vehemently not to go on this particular call. I mean, anybody knows whenever you get in a truck with Sam Galvagno, you have to like get out from underneath his shadow and his cape. So, there's all this like, heroic and lights and bat signals. So I think it's really interesting. This goes to a lot of the stuff that we talked about before. So interestingly enough, number one, we had heard about this call hours earlier. And I just happened to be in the office, and one of my medics, and I mean, this is a safe space for everybody. They're like, why isn't just flight doing it? And this patient was so unstable because the patient needed to get definitive care and needed to get surgery, that the issue was it was going for an aircraft. So by the time ground got paged out, there were a lot of people involved. And to Matt's point earlier, I immediately went up to the CCRU because there were all sorts of discussions about how to retrieve the patient. The helicopter can't take them. And this is where, and I beg and plead, like before we send all the resources and before we, get marching headlong into a situation which may be really difficult, let's figure out what the variables are and what the problems are. Meaning, what does the patient need and why, why is there a problem? And just to introduce another component of difficulty into this particular call, it was actually the judgment of a flight paramedic, a very difficult judgment to basically say, look, I don't feel comfortable taking this patient because the likelihood of arrest morale was too high. And that was where things got very complicated, because we actually had the transport there. We had the patient that was actively hemorrhaging to death, literally getting a bunch of blood on a pressure infuser. And every time they dropped her or stopped the pressure infuser, the pressure would go down. And what prompted this whole debacle was when they transported her onto the stretcher, because flight had one point in time wanted to try to make the trip. But the minute this person came off the level 1s and was not receiving product, the blood pressure tanked. So then you have this issue of, who goes, what's the imperative? And that was the reason why flight did not complete the first leg of the mission. So just to add some more nonsense into the mix here.
All right, well, I think we'll keep going because I don't know that there's a whole lot more. Like, I think that adds a lot, Ben, and we're going to get into that in a second. But essentially, Devin, why don't you give us the rundown on sort of what you got and what you found when you got there?
Yeah, so basically we knew that the patient had delivered a stillborn, became eclamptic in the ER. They did a post-mortem C-section, or I guess not really post-mortem because they got her back. But so once they got her back, we knew that she went up to surgery. She came out of surgery and they said that she was bleeding too much through the wound vac. So they took her back into surgery. When they took her out, she was still basically bleeding everywhere. Same thing, we knew that she had received over 100 units of blood, and they had called us for more of the blood, basically. We definitely grabbed as much blood as we could take, so 6 units of FFP and 6 units of packed red blood cells from the TRU. And we also asked the sending facility to give us as much blood as they could as well prior to us going there. Our primary concern was obviously the fact that she was her blood pressure was very dependent on the blood. We also knew that she was on 3 different pressors. She was on a bicarb drip and obviously intubated and on a ventilator as well. Once we arrived on scene, the patient's blood pressure actually seemed to be pretty decent. I believe it was in like the 110s, 120s.
Hey, Devin, I'm going to stop you real fast here and just sort of run the process of the case. Give me 1 second and then you can jump back in.
Yeah, no worries.
So yeah, like Ben said, the aircraft was dispatched, and I got a chance to talk to the flight medic that Ben referenced, and basically what they found was what Ben said. Profoundly sick patient. They couldn't make the transition to their stretcher, is really what it came down to. The patient could not come off the level 1. The other complicating factor to this is this hospital doesn't have a helipad on its roof. It's right around the corner, but you still have to go down to the ED, get in the ambulance, go around the corner, take them off an EMS stretcher, put them on a flight stretcher, transition them standing on the side of the road to the aircraft, and put them in the aircraft. So you're adding 10-ish minutes if you're quick, 15 probably realistically to kind of make that transition to your out of hospital time. And he felt like the patient wasn't going to make it. His quote to me was, "This is the furthest out of my depth I've ever felt in years of doing critical care transport." So that was a decision by them. And I know that when I first saw this case, and when a lot of people probably heard about this case kind of as it was going, it was like, why didn't the team take them? Why didn't the flight team take them? So I think that there's a lot of context, like you said, Ben, that kind of you have to add to this of logistical complicating factors and things like that. So that happened. They called back to the CCRU, sort of tell them what was going on, probably called Ben, told him what was going on, and then the MEC pseudo-go team got launched with the 3 docs we were talking about, and the MEC team. And I'll kick it back to you, Devin. This is what you guys found upon arrival, per what I got.
Yeah, so that's all looks correct. Basically, when we got in there too, it was kind of chaos. Everybody was running around. There was blood basically everywhere. Our nurse went straight over to managing the airway, which the patient was doing pretty well on the vent, and we decided to we ended up giving push dose pressor, as well as to get the patient more comfortable. The patient, I don't believe, had any sedation going, and our nurse can jump in here if she remembers. But the patient wasn't really on any too much sedatives and was kind of seemed to be awake and moving around a little bit. We ended up the sending facility ended up ordering some lorazepam that was given, and then we also gave a dose of rock as well. After that, we basically got the drips transferred over. We ended up basically just transferring the patient over, as well as keeping all the blood going. Dr. Galvano did an amazing job at having his own system set up for how the blood was being administered. We were administering at least 2 to 3 units at a time, as well as with FFP. That's kind of where the gist of getting the patient transferred over. We copied the exact vent settings to get the patient over. But other than that, the patient's blood pressure was actually pretty decent, except for when they were transitioning her from the mass transfusion thing to just getting her running with ours. And we did use pressure bags as well for our blood.
Quick question, out of curiosity, like how many units of blood and blood products are typically stocked in a blood bank at a hospital?
Not enough, apparently.
I mean, this is like, I'm surprised they had this much. I mean, I don't know which hospital it was, but it's sort of like an academic center.
And Devin can probably tell you, like, over the course of this particular transport, but this was one of the interesting things, Eric, because I was not, as Sam will tell you, I am a big fan of transport crews doing the transport job. And this crew was like, oh man, we should get the go team on every call. And I'm like, oh no, not at all. And one of the issues was we were running out of blood. And they said, well, they literally got to the point where this person's hemorrhaging to death. We don't have the surgeon. If this person stays here, we're gonna run out of blood. And so one transport synthesis for me was, are we gonna let this 30-something-year-old die because there's no blood at a hospital? Now this triggered the activation of the Red Cross. So when ASA said bring blood bank, I literally, when we got there, there was a freaking 50-pound cooler with like 16 units in it. So to your point, no hospital carries as much blood. But I think this was one of those where I was saying, multiple arrests. I mean, maybe we shouldn't move this patient because she's hemorrhaging to death. But the issue was, if this person's responsive to blood and there's still a volume component and they're hemorrhaging, if it's just an issue of getting blood to the patient, that's where we can assist with that. So we took our blood from, the GO team. The reason why the whole GO team got looped in was because that was the easiest way to get blood, which we fixed that issue. But by that time, it should be said that they called the Red Cross, and literally, it looked like the PRU with this particular ICU. I've never seen that much blood, with the exception of the second floor, when they give 100 units for a transcervical gunshot wound. So we definitely had a lot of help, but that was one of the things that basically urged us to get going down the road, because it was complicated in that transport process, right? If the patient was not getting blood, they were going to die, and at one point they were worried about running out.
All right, so Devin, you can kind of talk to this. You guys went to start stabilizing the patient. Like you said, you flipped your drips, you transitioned to the vent, and secured some more blood products from the sending facility. The one thing that I did want to hit on here was that there were some ventilator complications that sort of arose. The patient got bagged for a little bit. You want to talk to that a little bit?
Yeah, so basically, we were able to get the patient down to the ambulance without an issue, and we started noticing the patient becoming increasingly hypoxic, as well as the PIP pressures were increasing as well. So on top of having to basically juggle the blood issue, making sure every time the blood would ran out, our blood pressure would drop, essentially. So we were trying to manage the pressors, we were trying to manage the blood, as well as troubleshooting on the vent as well, which was nice to have all the hands with us as well. Ben stepped in and helped us with the ventilator. But basically, the PIP pressures were increasing. We were trying to basically increase the PEEP, thinking that it could have been trolley, or the fact that the patient's abdomen was so distended, most likely from all the blood that was accumulating in there as well. So basically, we ended up playing around with the vent settings while I ended up bagging the patient. I put that PEEP valve up to 20 basically, and tried to do basically like a recruitment maneuver kind of thing with the PEEP valve best I could. And every time we got the patient on the BVM, her SpO2 would increase and things would stabilize a little bit. So I don't remember exactly what the at-end vent settings were, but I do know that once we got the vent figured out, we were able to get the patient safely back on the vent after we figured out the settings.
Yeah, I can kind of jump in. I was the nurse on this call as well. So basically
Sounds like we should stop letting you run calls.
Yeah, that's kind of the consensus around the office as well. So basically, I think what we came to consensus was it probably was a trolley or something like that. After getting over 100 units of blood, it's surprising that it took her that long to even get there. But we were having hypoxia issues, but as well as she was very hypercarbic every time we got her on the vent. Her Untitled would almost tremendously just like skyrocket to the 70s, 80s until we bagged her back down. And basically our peak pressures were upwards to the 40s, the 50s. We weren't getting any volumes. And so until we bagged her, that was the only thing she was responding to. Ultimately, what we ended up doing on the Hamilton was just upping her pressure limitations to the highest they would allow, and just kind of letting her peak pressures get up, I think, to the max of 60. She was even maxing out as much as the Hamilton would allow us. And that was enough to finally get her volumes to an appropriate amount to get her N-titles down and her hypoxia corrected. But I think we had tried switching her to pressure control. We ended up going back to, I believe, volume control and handling it that way. But I think half the ride was, it's kind of troubleshooting the vent, as well as in between bagging her in the meantime, because she just wasn't ventilating on top of everything else. And we also didn't know her belly at that point had gotten so large from, she was hooked up to a suction device they basically took her off the the wound vac and had her hooked up to where I think she had put 3 liters out of her belly from the time we were there to the time we left, and we were at the bedside for maybe an hour. And so when we took her off that device, I can only imagine how much blood had accumulated in her belly at that point too. So all that pressure, I'm sure, pushing up on her lungs wasn't helping the situation either.
Sam, I don't want to steal anybody's thunder, but this is a great example of why, you know, sometimes more resources does not mean better care. We are very lucky that, you know, Sam knows the transport environment, and the critical care, the surgical critical care fellow knows the transport environment, because there were a lot of things that were going on. And this is where sometimes where you lose, it is easy to lose perspective. And very fortunately, we really tried to keep it focused on this patient's immediate life-threatening illnesses. One thing that we did not mention is the reason why it took all these physicians, because not only because everybody wants to go along for the ride, but there was this question of Reboa. And back to the other issue, well, why don't, if this person's hemorrhaging to death, why don't we deploy a Reboa en route, and we can basically occlude off her entire aorta and make everything happen? Well, this took quite a bit of time with the transport ultrasound, and it was disastrous, right? It did not work because the patient was morbidly obese, actively hemorrhaging. We couldn't see. And so yes, you can take an ultrasound and put it in the transport environment, but now you add into the exsanguinating hemorrhage, the morbid obesity, the hypotension, and the multiple attempts were not successful at even putting in that femoral A line. So I want to say there's a lot of discussion points, which I think are great for this particular course, but the only way we would stay on task was with this kind of like crew resource management mentality, where you said, okay, there's a profound issue with hypoxia. What's going on there? As Tori mentioned, we could not oxygenate the patient, so that required a bunch of troubleshooting. What's going on with cardiovascular? We needed a bunch of blood to actually stabilize this patient, a bunch of TXA, and go through that troubleshooting. And it took the two physicians to kind of work on the Reboa, which also was unsuccessful. And what are the other things that you could do and you could correct in the transport environment, similar to what we were saying with the previous case? So I think when these patients are at the extremes of physiology and technology, it really helps to kind of run through what you can temporize. And sometimes, you know, more necessarily is not better. I think in the end, what this patient needed was a whole bunch of blood, which was delivered, and we can still talk about the outcome there. So yes, by the way, Meg Dandy's question, there was a hysterectomy and there was an embolic, a uterine artery embolization, but the person was bleeding from the pedicles and the person was hemorrhaging from everywhere else. I think they opened up this person's belly. We went to the OR and there was just hemorrhage all over the place anyway. So just a couple of 2 cents to wrap up some more diagnostic and therapeutic conundrums.
Yeah, so lots of badness. I'm going to keep pushing through. It looks like you guys can see, and this was already hit on, they gave a push of Neo and a bunch more blood. This is what came out of, what I've got written here is what came out of the Go Team note, Sam Galvano's Go Team note. It sounds like you guys probably gave more blood than that, but that's what he had in his Go Team note. The PEEP was increased, you guys transitioned to pressure control is what I was told, and then the multiple attempts at Reboa like Ben talked about. And I also was curious, and I think I know the answer, but Ben, maybe you can kind of confirm this. Why was the Reboa done in the ambulance? Was it because it was a credentialing issue? Like once you're in the ambulance, you're in University of Maryland, you're on University of Maryland property, essentially. You couldn't do it at the bedside because of that, correct?
So we could have. I think the challenge was, as Devin can mention, there was this ICU was open. There must have been 50 people there, and the person was literally hemorrhaging to death, and we actually had good access. So the thought was, and this was partially, I'm probably a little bit to blame for this too, is we needed to get, you know, on the road, meaning it took us forever to kind of transition away from this ICU where there's 50 people, the flight crew, the ground crew, you know, the respiratory therapist, the janitor, the priest. I mean, there must have been, you know, I don't know how many people in there. It was so hot, as a matter of fact, like you couldn't even get in that room. So to then say, okay, let's bring in another ultrasound to put in a femoral artery catheter so that we can go ahead and put in Reboa, the decision was made, let's do all we can to transition her to our property. But to your point, we did think about that. The discussion was made because this person was on, I mean, I don't know, Tori can probably, and Devin can probably mention how many drips, but to transition a patient this sick off of their ventilator took, I mean, that just was taking a lot of time. And it was a very directed effort to get the patient back onto a transport stretcher.
Got it. Okay.
One thing I wanted to touch on too was me and Victoria, when we were giving the Neo, and we also had increased his epi to 15, we noticed that there ended up being no change. The patient was completely unresponsive to any push dose pressors that we were administering. we kind of were figuring either that she had no receptors left to uptake the medication, or she was bleeding out so fast that she was just bleeding out the medication, essentially. That was another problem that we ended up running into. So basically, this patient was completely only dependent on the administration of blood.
Cool. All right. Well, I want to transition to, and we already sort of talked about the too unstable to transport. That was sort of the first thing on my hit list here, and I think we beat that up pretty good. So we're pretty sure this was Taco or Trolley, right? Will one of the docs sort of run that etiology for me, just in case anybody on here is not familiar with those two, or that pathology?
I mean, one's just massive fluid overload. The other is a immune response to antigens in the blood. So you get this kind of cardiogenic and non-cardiogenic pulmonary edema that kind of mirrors ARDS. You know, one treatment is obviously diuresis if it's just overload. The other is far more complicated and just requires supportive care.
So you essentially get a cardiogenic shock, or like a cardiac overload
Pulmonary edema
on top of a ARDS picture.
Yeah, that was very frustrating. I don't think which system was working in this patient, Devin or Tori. I don't know. Like, I think everything was just, nothing happened the right way. The elevator.
Neurologically, she was working. That's
Thank you. Yes.
Yes, she was agitated. Yeah. That's one of the reasons I went to the head of the bed. Was first thing was to see what she was doing neurologically. And shockingly, she was opening her eyes and her pupils reactive, and she was moving. And once we decided we were going to be placing the Roboa, that was why we made the decision to give her some sedatives and some paralytics so that she wouldn't move or become any worse during that placement, which is the main reason why we decided to give those meds.
The one thing I want to hit on sort of on this, and you guys, sounds like you guys addressed this, but it's something that's worth rehashing because we see it over and over with all of the teams that are running the T1, is that pressure limitation. And keeping in mind that you've got a 10-point difference between your high pressure limit and your pressure limitation, and the pressure control, the CMV on the T1 can be very, very frustrating for that reason, which is why I think pressure control is a better mode of ventilation in some of these profoundly complicated ventilator patients, just because you have direct control over what you're doing. And that's, I don't really have any comment on that. It's just that it's something that I have personally seen teaching the ventilator repeatedly. That's something that we constantly run into problems with, is the pressure limitation issue. So indications for did this patient get calcium? I have no doubt that they did, but how much? And what are our triggers for calcium? And this is the new hotness in EMS critical care literature, and everybody wants to start giving calcium and all of that. But what I want you guys to kind of walk me through when I should be giving calcium, how much, which flavor, gluconate or chloride, and what's the difference? Asa, you want to try this one?
Right on. So other than obviously hypocalcemia, you notice in the labs, when you're doing resuscitation, usually I will start to think about giving calcium after the 4th unit of blood, but certainly by the 6th unit of blood. Your citrate factor ultimately binds to calcium, causing hypocalcemia. We know that the body doesn't work well with low calcium, both in terms of clotting and cardiac function. There is some suggestion that calcium is a natural sort of inopressor, and you'll get some inopressor-like effects from calcium as well. With respect to calcium chloride and calcium gluconate, I'm giving it in this case, which is obviously emergent, I'm giving calcium chloride. It's roughly a 3-to-1 gluconate to chloride. We tend, at least in the hospital, to shy away from calcium chloride because if it extravasates, it can cause tissue necrosis. But I've grown up in EMS and we've given calcium chloride forever. And provided you know how to put an IV in and that IV works, you're not going to have an issue with calcium chloride. So in these settings, I tend to give calcium chloride as I want the bigger bang for my buck more quickly than I do if I'm giving calcium gluconate.
Anybody else got anything to add on the calcium? Ben, how much calcium did you guys give this patient?
You know, I'm embarrassed. I can't remember because there was thoughts before and after because this patient was, as you mentioned, hypotensive. So I don't remember the total, quite frankly. But it was, our triggers are, you know, we have it in protocol for the, I think every 4th unit of blood, but I think, as you mentioned, there's good research now for hypotension in hemorrhagic shock. I don't remember the total. Patient got quite a bit of bicarb too.
So I know right before we left the bedside, we did give some like 2 amps of bicarb and 1 amp of calcium chloride, and she had received upwards of 100 units. So I know she had already, that was one of our questions when we got there. We had her potassium and her calcium and all that checked as well. But I know en route, we did end up giving a dose of calcium gluconate because I think, we gave probably close to 15 or 16 units on the way as well. So even though she had just gotten a dose, I think, like halfway through the ride, we all kind of were like, hey, we should probably give a dose of calcium because we don't really know how many units.
You gave gluconate or you gave chloride?
We gave gluconate.
Okay.
Yep.
All right. Good deal. Anybody got anything else to add on the calcium and sort of triggers and that sort of stuff? Any other panel members?
I mean, I would just say, I think this is the one thing where we don't necessarily have to complicate. I think if you have hemorrhagic shock or a profound shock state, I mean, I really look at the risk benefits, and, you know, a dose of calcium gluconate, especially in the hypotensive patient refractory to therapies, is really not likely going to hurt you. So I think my practice is somewhat changing that I think about it early, in addition to the standard trigger of if you're giving, you know, product. I think there's less research on the bicarb side because that gets into a whole other issue of, you know, metabolic, you know, compensation and how much should we give it. But I think calcium is pretty safe. And, you know, if we also agree that it has a role in clotting factors, perhaps we should be giving it a little bit earlier than waiting for several blood units to go in.
Thanks for that transition, Ben. Why the bicarb? Just for the acidosis, just for the known acidosis? You guys were just trying to combat that to make your pressors work?
Which is likely secondary to hypoperfusion, but yeah.
Okay.
I was going to give intracardiac bicarb, but then I realized I wasn't in the true.
I think the other thing for us
shouldn't stop you, Ben.
Thank you.
I think the other thing for us too was that we also had, you know, we kind of ended up dividing up into teams where one of the 2 surgeons were doing that, and Victoria and Dr. Launer were working on the vent, and then I was basically going back and forth between bagging and hanging up the blood as well. It kind of turned into where we were all kind of trying to focus on all these life threats where it was kind of like Tori said, in the middle of the transport, we were like, wait, how much blood have we given? We probably should be giving bicarb because we don't know how many bags we've hung thus far. So that was definitely part of something that we should have kept track of better, I think.
Good deal. This kind of goes back to our push dose pressor conversation on the last case. Neo, epi, I know you guys gave Neo as a push dose pressor. So Neo, epi, or vaso. I know I've seen some argument for vaso in the traumatic or hemorrhagic shock patient. But as a push dose pressor, would vaso have been a potential option in this patient? Or it sounds like the Neo worked. Would epi have worked just as effectively? Does it matter at this point? This patient's so profoundly sick. Does it matter push dose pressor?
You know, it's so difficult to figure out because this person was on everything right at the time that we were there. So I think one thing you can say is that there may be a role for vasopressin early in the state of hemorrhagic shock, but this person was way downstream. And I think the Neo was actually helpful for us because initially she was quite responsive. And so although I don't know the ideal pressure, if you get a response from vaso, you know that perhaps maybe we still have room. Maybe there's still some alpha receptors that can, respond. So I think like everything else, these are clinical decisions. But unfortunately, this person was way downstream in her, physiologic decompensation. So we weren't like dealing with an early hemorrhagic shock where, you can say, hey, let's give a small push dose of vaso. So I think we elected initially to, she was initially on all three, I believe. She was on a vaso drip, an epi drip, and she got some neo. So I think you have to look at it and then see if they respond, because that told us quite a bit that she was still volume responsive, which made us think that maybe we're still dealing with somewhat of a functional heart, that she can maintain her blood pressure. Maybe there's still some, vaso or alpha receptors that we could deal with. So again, just using clinical judgment after administering all these vasopressors and judging by her, her response to them. It was very difficult to ultrasound too. I do recall we were able to get a look at her IVC, which was not plethoric at all. But again, I mean, take that for what it's worth when she's exsanguinating and on a vent. This is where, again, too much information. We really struggle with what to do with ultrasound other than give her more blood.
Sure. So this is something that I know that we've struggled with on the Hopkins, maybe not struggled with, but something that's been a point of conversation on the Hopkins side, and it makes it a little less complicated for the University of Maryland folks, Ben, because you are the medical director for both the air and the ground side. But our partnership with Stat Medevac sort of creates an extra layer of medical direction and kind of operational challenges, I guess, or operational hurdles. Asa, I'd be interested to hear your conversation and have you and Ben sort of talk about this ground to air transition and how we do that most smoothly, because neither one of, it's not the same equipment, it's two separate companies, there's some extra hurdles, it's not all one team. So they're on both sides, there's a hurdle logistically for moving from one to the other. How do we streamline that? Because I think this is something that it's happening on the sickest patients. So I think streamlining it makes the most sense. So I'd be interested to hear both y'all's thoughts, or anybody's thoughts on how we streamline that process.
Sure. So two things. One, if you have the opportunity to take one of the on-scene clinicians from the ground to the flight side, that I find often helps, because there's continuity of care. There may be operational and logistical barriers to that, but if not, that is something that I find very, very helpful, because you have less sort of handoff stuff, less gets lost in translation. You have one person that was there from the start and can continue care. So I certainly advocate for that. The second is that if there's going to be different sort of medical control or different physicians involved, there needs to be a physician-to-physician handoff and update about the care. Because otherwise, you're spending more time on scene. The crew is already taxed taking care of the patient. And the last thing we want is for them to rehash the entire story to a new group of physicians or a new medical control physician just to get things that, they've already been granted orders for, or that, obviously the other physician needs to be brought up to speed on. So continuing care, and then doing a physician-to-physician handoff, and really offloading that work from the scene provider so they can end up doing the work on the patient, which is what they need to do.
Ben, any thoughts on that?
I mean, I'm very biased, and those of you that work with me know this. I think you've got to work hard to basically make sure everything falls under the same umbrella, so to speak, or underneath the same dome, to use a Hopkins analogy, meaning that we see the same. These are patients that are so sick, and a lot of these variables are stuff that we can control. So to the extent possible, and we've had this good relationship with PHI. I see Topper Woods is on the phone, and Joel is. We try to say, hey, look, even though PHI has national protocols, if you're working for Express Care, we'll unify the medical direction, because even one umbrella doesn't solidify all of that, and it doesn't do away with all the controversies. But when you're dealing with critical care transport, I think an overall goal in terms of systematization should be to utilize the same equipment, same controls to the extent possible, same protocols.
So the last thing I want to hit on, go ahead.
I was just going to say, I think the flight crew timed out, so we couldn't even. And they were there for optimizing so long, and I think we didn't have that luxury. You bring a good point, Asa, but I think the crew had to actually leave because they were remotely positioned on that helipad, and we're going to time out, as I recall.
The only other thing that I wanted to kind of throw out there, and I don't know much about this, but I know there are teams out there that are doing it, would be junctional tourniquet versus Reboa. And I literally know nothing about sort of the evidence on that, but is there an argument for the junctional tourniquet in a patient like this? And how does it compare to a Reboa?
This patient was bleeding out of her uterus, right?
Yep.
Yeah, so I don't think a junctional tourniquet, which is going to more tamponade out like the femoral arteries, is going to be helpful. Reboa, good. I don't know. I mean, in DIC, you're at risk of bleeding everywhere, but I guess you would at least get some control over the main source of bleeding.
Sure.
Yeah, I mean, it's heroics either way.
Yeah, absolutely. Okay. All right. Well, we're pretty much right on time. So just a little bit of follow-up. Patient extremely sick. Gets cannulated for VV ECMO in a hybrid OR at trauma. Transition to the CCRU after the OR. Can't get flows, worsening, and expires, unfortunately. So I think this was very, very heroic efforts by the team, and somewhat expected outcome. And I think the team did a phenomenal job moving this patient. I think this was one of the most complicated and one of the most difficult cases I think I've ever seen, and probably extremely logistically challenging with like Ben alluded to, the 45 people in the room, and I can feel the heat from that room. Like when he said it was hot, all of us that have been doing this long enough and have been in these really sick patient rooms, it's like you're hot just because you're working, and then for some reason they turn the heat up in every single one of their rooms, I swear, or shut the air conditioning off. So great job by the crew. I have nothing more to say than that. Phenomenal job. Anybody have anything to add sort of as we close up here?
I just wanted to put in a plug in for what you're doing. I can't say enough, and I apologize for being late, but like the crews, the medical direction, Sam, your efforts in doing this, I think this is one of the most important efforts to be able to share these difficult experiences with similar and like minds. As Asa and I like to say all the time when we're not laughing at each other, I think it's a pleasure to collaborate, and I can't say enough about the utility of this forum. So please feel free to send us feedback. We certainly don't know the answers, rely on our colleagues, but thanks to PHI, Hopkins, everybody else, hopefully MedStar, who else will get on this collaborative, really helpful, and it really echoes why we do what we do. So thanks to your leadership, Sam, and great stuff.
Well said. Completely agree. Thank you.
Good deal. All right. Well, thanks all. We recorded this, so please get to the folks let the folks know who weren't able to be here. The recording will be going out sometime in the next week or so, probably, depending on how busy Asa keeps me. And we'll get some stuff out there. So thank you to everybody for being on.
All right, nice work.
Y'all have a good day.